We're here for the talk, Advanced Directives Are Not Enough, Navigating Serious Illness at the End of Life. This is Grant Marylander. Grant retired from law practice after 35 years to pursue work in hospice and palliative care. He currently serves as the Palliative Care Coordinator at Boulder Community Health, where he has led more than 3,000 patients' meetings concerning serious illness, goals of care, and end-of-life planning. Grant is a social worker, board-certified chaplain, and certified grief counselor. Thanks, Grant.
Morning.
Okay, that's good.
So I am your speaker.
That's
And I appreciate the fact that you're willing to give up an hour to talk about death and dying. It's not an easy subject. But here's the honest truth. We're all going to die. We can't fix that. We're going to have a terminal illness, or we'll have frailty as we age, and then we'll ultimately die. The challenge is our medical system isn't really good about supporting us at end of life. Medicine focuses on fixing the problem. So the adage I use when I talk to patients and families is, medicine is, if all you have is a hammer, everything looks like a nail, right? So doctors want to fix. But here's the problem. We could fix something without changing the outcome. And we can fix something without reaching your goals. So my hope today is, at the conclusion of our time together, you'll have some tools so that when you are confronted with this, or when a loved one is confronted with this, you'll be able to match the treatment options offered by physicians to what is important to you. And that's what we're going to talk about today. And we're a small group, so I want to encourage questions as they come up. I might ask to defer something until a later point if it matches with what I'm going to talk about. But if something comes up, you have a question, feel free to raise your hand, okay? So this is Senior Law Day, but I am not talking about law, I'm talking about death and dying. And I know that from a lawyer's perspective, and honestly from a lot of doctors' perspectives, we like to talk about advanced care planning, right? How many people have, say, a living will or a medical power of attorney? Here's the problem. You're trying to guess what the future looks like. You're trying to guess what is important to you in the future. It doesn't work.
Right.
It doesn't work.
Well, and people don't pay attention to it in the hospitals.
And that's very true too. So I've led about 3,000 patient meetings. And I can tell you that I have never found a document that changes the conversation. Because what someone said years ago doesn't track where they are right now. And the only advanced care planning document that I find helpful is the medical power of attorney. But that is only helpful if you pick the right person. So what does that mean? You have to pick someone who knows what's important to you. Okay? You have to pick the person who will honor what you would choose for yourself. And the third one is you have to pick someone who could imagine a life without you.
Mm-hmm.
So let me give you an example. I had a patient, she was in her 80s, incredibly good health, very robust, hiked, skied. She had had a massive stroke. She was in the ICU, supported by mechanical ventilation. Her spouse was her MDPOA, and she had 3 adult children. And I met with them. And they shared that this patient valued her independence. She never wanted to be in a nursing home. she would never want a long course of rehabilitation. And that's what she was looking at if she survived. And so we talked about choices. One was to compassionately extubate and allow a natural death. The other was to stay the course, okay? So they told me what her values were. So what did they choose? Who wants to guess?
Stay the course.
They chose to stay the
Yeah.
course.
I've seen that with
Good
families.
enough, Mom.
So here was the problem. They could not imagine a life without her. So despite what she would have chosen for herself, they stayed the course. So
Well, isn't
How
there
long
also
did
an
you do
element
that?
of guilt in there, that you feel like you might be hastening someone to their death and you might be responsible for it, which I think really complicates a lot of end-of-life decisions?
there, at times there may be, but what I generally tell families is, if you are honoring what the person would choose for themselves, you are always making the right choice. And that tends to help.
What happens if you don't have a family? Because there are many, many people who are aging solo.
Yeah. So if you're unbefriended, you don't have family or friends, what happens is we choose a physician as a medical proxy. And that physician, who knows nothing about you, then has to somehow determine what to do, what you would choose. It's not ideal.
But
But
that's where your documents might help.
They might. Anyway, so how do we change what happens at end of life? It's really about educating either the patient or the family and having very candid conversations about treatment choices. Because if you don't align your goals with your treatment options, you're more likely to undergo a procedure that is not beneficial and keeps you from what you really want. So let me give you an example. There was a study of people with lung cancer, and they divided it into two groups. One group just met with their oncologist and went through whatever the oncologist was recommending. The other met with their oncologist, but they also had palliative care support. And if you're unfamiliar with palliative care, it's a subspecialty of medicine that focuses on helping you have the best quality of life while you treat, and also helps you explore your goals so you can match treatment to what your goals are. So what this study found is the people who had both oncology support and palliative care were less likely to be on chemotherapy towards end of life. They stopped it earlier, okay? They had more time at home with their loved ones. They had fewer hospitalizations. They had higher quality of life measured by things like anxiety and depression, okay? They were more likely to enter hospice sooner. Their medical costs were lower. And here's maybe the one that's most startling. They lived 25% longer. Sometimes when we focus on your quality of life, we make sure you feel as good as possible, we make sure you're supported emotionally, you tend to do better. Okay? One other thing I just want to remind you is physicians are notoriously bad at estimating life expectancy. The overwhelming majority will overestimate by as much as 500%, and fewer than 20% will underestimate. Okay? So when you're talking to your physician and you have advanced cancer and they say, we think you could live a year, keep that in mind. We don't have crystal balls that work. So let's talk about CPR, one of the most common questions we have when we're approaching end of life. So here's the problem. When we talk to someone about whether they want CPR, this is how the conversation often goes. If your heart stops, do you want us to resuscitate you? If that's all I ask you, how many people would say yes? Right? But that's because we do a terrible job explaining what CPR means, okay? And we haven't talked about what CPR will do. One of the things I want you to always remember when you're offered treatment is, what is it a bridge for? Okay? My goal is to be independent. Does CPR get me to that? I want to have more time with my family. Will CPR get me to that? Okay? That's important. How is it a bridge? The problem is, when we're older and we have health challenges, the risks of CPR often far outweigh the benefits. You've all heard them talk about CPR, they'll break your ribs, okay? If that's all that CPR did, it would be one thing. But we have significant risk of damaging our organs, causing internal bleeding, okay, and brain damage. And further, if we are successful, we have a long course of rehabilitation. And in terms of success, when we're older and we have a serious health condition, about 68% of us won't survive. And for those of us who survive and make it out of the hospital, another 25% will die within a few months. And we'll have a long course. So, CPR has serious long-term consequences, including, as I said, brain damage. And we're less likely to recover from it. So when someone asks, do you want CPR if your heart stops? And what we're talking about is, do you want CPR if you have a natural death? Think about, will it be a bridge to what matters to you most? Does that make sense?
Yep.
Just, I don't know if this is the right place, but
Yeah.
what matters to me most is like being independent. Name some of those choices that I could want. Something.
It
Family
does.
time.
Yeah. People who value their independence, right? Who don't want to be in a nursing home, right? And remember, we're talking about as we're older, as we're frail, as we have serious health conditions. CPR was designed for the young, healthy person who has a cardiac arrest, but otherwise will do well. And CPR is not you never do it at a certain age. I don't say that. But you have to think about, as we get older, as we're more frail, as we have health conditions, what is it a bridge for? And keep this in mind. If I have advanced cancer, okay, my heart stops and I stop breathing, I have a natural death, my cancer has killed me. CPR will not cure my cancer. So if you bring me back, I still have advanced cancer and everything that goes with it, except now I have all of the other problems associated with CPR. This is a new speech for me. Normally, I've been doing this for about 8 years. And in the past, I've talked a lot about values in advanced care planning. And that was my training and that was my orientation. And the more and more I spent with patients and families and being with people at end of life, I really thought more about, was I doing a disservice talking about advanced care planning and not about serious illness conversations? And I realized I was. So this presentation this year is as close as I get to the one I want to give. And I'll just share with you, the one I want to give is, it's okay to die, right? Because we fear it. We have death anxiety, right? And a lot of us, maybe we won't admit it aloud, think that we're kind of different. We'll be the 1 in a million, right? The odds are we won't. And so I really want to help us think about the hard choices now and be prepared to ask the hard questions when it comes for our time to die, okay? So CPR is not just chest compressions. It also includes intubation, because if we don't have a protected airway and we can't get you oxygen, we will ensure that you will have brain damage, okay? So if you say do chest compressions but don't do ventilation, we can't ethically do that, all right? But here's the problem. Ventilation carries its own risks. And we talked, this became really an issue for us when the COVID pandemic started, right? I was on the ethics committee where we had to decide how we were going to triage ventilators if we got overwhelmed. But even outside of the pandemic, intubation carries a lot of risks, again, as we get older. So for the elderly with a health condition, and it could be heart failure, it could be cancer, it could be pulmonary fibrosis, it could even be diabetes. You have an extremely high risk of death within days to a month of receiving that intubation. And for those who survive, you're at great risk to have significant disability afterwards. Okay? So yes?
Isn't it true too with COVID that people who were intubated, a lot of them died because of that?
They didn't die from the intubation. A lot of them developed a condition called ARDS, which is a very severe and often difficult respiratory disease. What we did find in COVID is that we could defer ventilation far longer than we realized. We could let people hang out at lower oxygen saturation and come through it. And in some cases, depending on your health prior to coming into the hospital, ventilation was a bridge. But I saw people who had long-term ventilation who ultimately survived, but they survived with pretty significant cognitive decline and physical decline. We hear about long COVID, but the longer you're intubated, the longer your recovery is, and your chances of returning to baseline are extremely low, okay? So, remember the bridge question, right?
Well, bridge, and there's also off-ramps.
Yeah, and that is.
Are you gonna talk about that?
I will.
Okay.
I will. So, is intubation consistent with my goals? Will it get me to where I want? Many people I talk to don't want to live in a nursing home. And nowadays, that's more true than ever. Nursing homes are really under pressure due to COVID, okay? People are leaving the medical profession in droves and are leaving long-term facilities in droves. So even what you consider the best nursing home is probably not what it was 5 years ago.
Can you be really literal? They stick it down your throat. What
Yeah.
really happens?
So
Just be
intubation,
literal.
right, so intubation is we literally take a tube and we put it down your throat and we attach it to a machine that regulates how much air pressure is coming in and the percentage of oxygen that you're getting, okay? It is helping us breathe. Without it, we would die, okay? But sometimes there are things worse than death, depending on who you are and what your goals are, okay? So if the goal for ventilation is to survive weeks or months, and you want to return to baseline, mechanical intubation is a failed therapy. It won't get you there, okay? And the longer you're intubated, the harder it is. And someone asked the question about guilt. If you're at making this decision for a loved one, and you say yes to intubation, and it does fail, and then you have to say yes to compassionate extubation, for many people, that's challenging, right? As opposed to simply saying, ventilation doesn't align with my loved one's goals, we're going to allow them to have a natural death. Let's see how I am on time. Anyone have any questions?
You're gonna get the feeding.
I'm going
feeding or
to talk about artificial nutrition, yeah.
drink, yeah.
Yeah. Yes,
Just
sir.
an observation in terms of, you talked about picking someone to help you during this journey. We often pick those that are our peers. And we picked them years before will you ever
Joke like that.
fall ill.
Yeah.
And by the time we do need them, they may be in the same or worse condition than we are, or have moved closer to their family and friends in another state. And it's hard to think of someone a generation younger who's going to be around should you be in your 80s or 90s. They're going to be in their 60s or early 70s.
Yeah.
You know, and you know, thinking of someone a generation younger to help you if you don't have family may be even a greater challenge.
It is, very true. Did everyone hear that? It's, as we get older and we age and our friends age, who we picked earlier may not be in a position to help us make those decisions, right? And finding someone who is appropriate and perhaps a generation younger is challenging in itself. There are people who specialize as professional medical powers of attorney. In some instances, it works well, and if it's someone that you trust, it's better than having no one at all. Because having a physician who knows nothing about you make that decision is poor. And having us search for your long-lost cousin who doesn't know you, trust us, that's what we do. And they're making the decision, that doesn't go well at all, okay? So it is a problem. It's a huge problem.
You know, I'm a solo ager, and I'm in a group, and we've been looking for people we can hire to help us with this, and there's almost nobody
Yeah,
around.
it's
And
not,
if they were given a name, they don't even bother to return the phone call.
yeah, it's not a popular profession. Yes.
I've asked my attorney, who knows me and knows my family, and my son is bipolar, and so we did a special needs trust.
Mhm.
I want her to manage it because I don't even want my daughter to, because they fight all the time, and I don't think she has his best interest. So
Yeah.
I'm hoping she's much younger, that she's
Yeah.
can do it.
Yeah. Yes, sir.
Just to get back to code for a minute, if you opt, or if somebody opts for, not to being intubated, and you just die normal, is it like pneumonia? Is it basically you're suffocating? Is that?
Yeah, and that's a huge question, and I'm glad that you asked it, because we worry about if we don't do it. Someone's going to suffocate, and they're going to suffer,
Yeah.
and they don't. You do die because you no longer can get the oxygen you need,
Mhm.
but just like in hospice, we're very good about alleviating distress at the end of life. And I'll talk more about hospice, but it's a great question. And it segues well into the question of artificial nutrition. Okay? So feeding tubes usually come in two forms. One can be through your nose, and that's short term. And one is a tube in your abdomen, and that's long term. Okay? It's usually provided for one of two reasons. One is you're just not getting enough nutrition, right? You're not eating enough, you're losing weight, you don't have the calories. And the second is when we aspirate, and that's when we take in food or liquid, and rather than it going into our stomach, it goes into our lungs, and we get pneumonia. So those are the two principal reasons why we have artificial nutrition. We're talking about end of life. So we've gotten to the point where we have a terminal condition. We see it most often being proposed, for example, people with advanced dementia, and we're seeing it for people with advanced cancer. So here's the problem. At that stage, artificial nutrition does not change outcomes. It doesn't reduce or eliminate the risk of aspiration. It won't improve your nutritional status. It doesn't improve your cognitive status, and it doesn't extend your life. Okay? In addition, feeding tubes have their own risks. They have the risk of aspiration. Again, it has the risk of infection. It can increase agitation and discomfort, especially with people with advanced dementia. Okay? We often see patients with advanced dementia constantly pulling at their tube. They don't understand why it's there, but they know it's causing discomfort. So why do we do it? A couple of reasons. One is the physician. All I have is a hammer, everything looks like a nail. Your nutritional status is poor, we'll give you a feeding tube, even though it doesn't change outcome.
How much of this is due to the litigious nature of our society as well?
I don't think it has anything to do with it.
Really, at end of life?
Yeah, I don't. The other reason is, in many of our cultures, what's one of the ways we show love for someone who's sick? You give them food, right? And sir, just like you asked the question about suffocation, we worry about starving our loved ones, right? But here's the thing, at end of life, our body naturally no longer wants hydration or food. That's just part of the dying process. And in fact, we've shown that hydration actually increases discomfort. It doesn't diminish it. So while instinctively we worry about starving our loved ones, we're not. And when we worry about nutritional status, we're not actually improving it with artificial nutrition. I also see it a lot in patients with advanced cancer. Now, at some point, when our cancer is so advanced, our performance status, our ability to do basic things in life, getting dressed, brushing our teeth, all those things diminish. We have significant weight loss. And pretty soon, we're at the point where we can't tolerate treatment any longer. The risks of chemo, which is a poison, are so great. Unfortunately, oncologists say, well, you're not in a position to get treated now, but if your strength improves, we could talk about treatments. Okay? So here's the problem. My cancer is growing, right? Continues. And when I'm not getting treatment, it certainly is going to progress. So as, in theory, I'm working on getting stronger, my cancer is getting worse. So where are the chances are that I'm going to get stronger? They're non-existent. And we also know, study after study has confirmed, artificial nutrition for advanced cancer does not improve performance status, and it does not extend our life. Any questions? Yes.
Quick question. If somebody is not getting enough nutrition, doesn't want to eat, is the time period usually like a 2-week period that they die?
Yeah.
Yeah.
So first I'll tell you what I tell all my patients and family. My crystal ball is broken. Generally speaking, when they're not taking in anything, and hydration is perhaps more important than food, okay? On average, we can say it's a couple of weeks, but there was one case where a person was getting oxygen, and that alone provided enough hydration for them to live a number of weeks. But as a general rule, yeah, about 2 weeks. But usually you have so much more going on, right? The person is so frail for whatever reasons that they've lost that. It often can be sooner. Does that answer your question? I want to talk about dementia. It's perhaps, at least in my experience, and I will speak for myself personally, it's the terminal condition that most of us fear most, right? I talk about dementia as a thief because it steals a piece of us every day. There are no medications that change the course of the disease. At best, they can mitigate symptoms for a short period of time before they become ineffective. Now, I'm going to step outside my lane when I talk about this because I'm not a physician. But I've read the studies, and many dementia patients I encounter on Aricept or Namenda. And I always encourage them and their families to have a really candid conversation with their doctors about what the studies show about their efficacy. Because currently, we have no medical treatments for dementia. Here's the good news. There's actually two things that we can do that's within our power that can slow cognitive decline in a significant portion, and in some cases, improve cognition. And they are focusing on hearing and sight.
Hearing it.
Sight.
Oh, like that.
So there's a huge correlation between hearing loss and dementia.
Wow.
And it's something we often just neglect. We don't even think about it. And nowadays, you're able to get hearing aids over the counter. I'm not sure if they're actually out now, but the FDA has approved it. So you don't even have to go to an audiologist for yourself or for a loved one. So if you're worried about a dementia for yourself or for a loved one, the two things I would strongly encourage are that you have hearing regularly checked and you also work on sight, okay? And there are also some studies, they're mixed, some studies that talk about exercise, both from a preventive perspective and from a cognitive improvement. And I can tell you that there are good studies, in my opinion, that when we have mild cognitive impairment, which is often, but not always, the precursor to dementia, exercise and sociability are huge as helpful treatments that last much longer than any medication a neurologist or a primary care physician is going to give you. Yes?
Going back to the hearing and the sight, particularly the hearing, I personally have experienced a couple of family members who we believed were getting dementia, and when they got hearing aids, they were back to normal.
Yeah.
So there's the opposite.
Yeah, absolutely. It's huge. I mean, I'm hearing challenged, and when I got hearing aids, my spouse is here, she can attest to that, my world opened up completely, right? When you can't hear, the world gets real small.
Plus,
right?
you don't want people to know you're not hearing.
Yeah.
And so we thought, oh, my mother had dementia, oh, my brother's got it, and that was not the truth.
So again, when we're thinking about treatments for someone with advanced dementia, ask yourself the bridge question. Will this get us to the goal? So where does this come up most often that I see it? Broken hips and femurs, okay? Advanced dementia, people often will fall. Falls are very common. Our bones are brittle, and we break hips, and we break femurs. And if you go to an orthopedic surgeon, he or she's going to say, of course I can fix it. It's not a big deal. It's a big deal,
Yeah.
okay?
Oh, yeah.
You have long recovery, you have the effects of anesthesia, and rehab is extremely challenging. And the other part is, we have advanced dementia. Leaving a familiar environment is very disruptive and has a really deleterious effect on us, okay? And when we come out, our baseline is going to be greatly reduced, okay? And the next one we talked about somewhat is nutrition and aspiration. With advanced dementia, it's very common for us to suddenly have either swallow challenges where we're aspirating into our lungs, okay? Or our nutrition is just poor, right? We can't feed ourselves, our interest in food is greatly diminished. So, at that point, I give a feeding tube? What is my goal? If my goal is to have a loved one live as long as possible, and that's the only thing I care about, a feeding tube might, and I think it's questionable, might be consistent with that goal. But if I'm hopeful that they're gonna get back to baseline, it's not gonna happen, okay? If I'm hopeful to improve their cognition, it's not gonna help. If I'm hopeful to give them a better quality of life, it's not gonna help. So ask yourself the bridge question. It's okay to say no when someone offers a treatment. Okay? You have that power, you have that right, and you're honoring the person you love when it doesn't match what they would want. And finally, heart conditions. I have a leaky valve, right? I have arrhythmia. I need a pacemaker. I need open heart surgery. At end of life, how is that meeting my goals? Because if you think that recovery from a broken hip or femur is hard, imagine what it's like when you have advanced dementia and now you're recovering from heart surgery.
Sorry, Grant, 5 minutes, please.
5 minutes?
5 minutes, yeah.
Oh,
10.
Thanks.
I have 12 minutes until 11.
Yeah, we were doing 45 minutes for each.
Oh.
segment.
Let him go, come on.
All right.
I know, is that fascinating, but we
Yeah.
have a speaker.
So let me talk about two things, and I'll do it quickly because I also want to have time for questions. First one is, I talk about goals for yourself, but I also want to remind you about your loved ones. When we have serious illness, when we have advanced cancer, when we have bad heart disease, and our loved ones are caring for us, we have to remember the toll it takes on them. Study after study has demonstrated that if you are a caregiver for someone with an advanced disease, you have declines in your health, you have emotional challenges, including pretty significant depression, and you have a risk of increased mortality. So as you think about what you choose for yourself, I encourage you to think about the effect on loved ones. Okay? And then, because I'm short on time, let me just talk about hospice. Hospice is not about helping us die. It's about helping us live as well as we can for whatever time we have left. In my view, hospice is a treatment option. Rather than going to someone like your oncologist who says, well, I can try the 5th line of chemo, which means I'm 5th line away from the gold standard and nothing else has worked. They could also say the other treatment option is to support you for quality of life and symptom management and have you go into hospice, okay? Hospice is focused on goals. Hospice is one of those areas that have a bridge to what you want, okay? And it's not a trap for the unwary. If you change your mind about hospice, you can revoke at any time, okay? And hospice doesn't mean no treatment. If you get an infection, you can have antibiotics. If you have heart failure and you get edema, right, you can get diuretics. And hospice doesn't just focus on you, it focuses on the people you care about. Okay? And finally, it's a Medicare benefit. So 100% of hospice is paid for by Medicare.
Isn't it true, though, that most people delay going into hospice way longer than they should, so they can't take full advantage of the benefits?
In my experience, yes. People, because we get back to the same problem,
Dying.
the flaw that I see in our medical system, and that is treat till the end. You have something, I'm going to fix it, treat till the end. So where am I on time?
You have a few minutes. Questions?
Hospice was great with my husband.
Yeah.
And they had a sense of humor, and they titrated his medication so he still was awake enough to talk, you know, and It was the best 2 months of our marriage,
Yeah.
of 20 years.
Whoa.
And I will say, hospice is a gift that I gave my father, and so I hope my kids can give me that gift as well. Yes.
What do you think about long-term care insurance? We haven't mentioned it.
So here's the challenge with long-term care insurance. The last statistic I saw is about 13% of people who have long-term insurance actually use the benefits. And part of the problem is there's usually a significant wait period, right? Between 60 and 90 days. Well, before you think about it, and then when you absolutely need it, you're gonna wait. And a good number of us will die before we ever get it. If you have it, my advice is do it early. Don't worry about running out of your benefit, okay? Because I've never seen someone run out of the benefit. Any other questions? Yes.
How do you deal with a physician who is treating somebody with cancer? You know, and you know they're not gonna live that long. And when you mention palliative care or hospice to them, oh, no, he's not ready for that yet. There are other things we can do, so he wouldn't even discuss it with the family.
That's correct. And that happens all the time, where people, first of all, confuse palliative care with hospice, but they also say, hey, I'm gonna treat. And I will tell you, I have had numerous cases where an oncologist is offering treatment literally days before someone dies, and I'm trying to think, I know of at least one case where they've offered treatment the day the patient died.
Jesus.
But I'll also tell you this, the standard of care is if you have locally progressed cancer or you have stage 4 cancer, you must be, the standard is you must be referred to a palliative care provider. But it doesn't happen.
What's the difference in palliative care?
So palliative care is for people who continue to treat, right? It's supporting you to make sure your symptoms are well managed and that we are matching your goals with what the treatment options. Hospice is for people at end of life, but by Medicare's definition, we reasonably expect you to have 6 months or less, and you are focused on quality of life and comfort and not life prolonging. But I will tell you this, just like that study, people tend to do better and they tend to live longer when they go into hospice earlier. All right, I think sadly my time is up. I really appreciate you coming out this morning and being with me.
Great, thank you.
Good job.